Good morning, everyone. Thank you for joining us in this second webinar from the TBPPM, our public-private mix online community. We're really excited that you are all here. We had 75 people registered and interested in this topic, and we have two excellent speakers with us this morning. Guy Stallworthy is based right now in India, where he's speaking from, and Monica Diaz is joining us from Geneva. I'm just going to give you a very short introduction on the process, and then we'll jump right into both of the speakers' presentation because they have a lot of interesting things to join with us. So thank you for being here. While you are, I'm going to be admitting people into the call while we are speaking. But we're going to just start with the process. So we will be recording this for everyone, if you're okay with that, so that we can later on share this also on our website and that people can look back at our talk while able to join us right now. It's about 1 hour. We are having two people present today. And what we are proposing is that we let the speakers present. They will be speaking for 10 to 15 minutes. Immediately after their presentations, you will have a chance to ask for clarifications. But if you have any comments or bigger discussion points or questions that are of a larger subject area, please keep them until the end so that we can have a joint conversation and a discussion with everyone at the same time at the end of the session. So that particular discussion we will be trying to coordinate with the chat function. You are all on mute right now, so if you have any questions, please feel free even during the presentations to write them down in the chat or let me know that you have a question. I'll try to coordinate to either bring them in during the presentation or afterwards, and for sure trying to kind of moderate. There's also on our website, we have a page opened for discussion. So any questions that you have that you feel are not addressed right now and that we don't have time for in this hour, please feel free to bring them forward on our site. Both speakers are available to answer afterwards to some of the questions. And we can also, as a group in general, we can be joining together to basically discuss on our site. So, without further ado, I would like to start with Guy Stallworthy. He's going to be talking about the landscape document, which I'm showing here. It's basically the background document, the reasons why, the context, why are we looking at engaging private sector providers into TB control, TB care, and TB prevention. He will be looking at some of the challenges and opportunities, and I am really excited to hear him. He will be also presenting with a presentation. So please have a look at everything. We will have the presentation afterwards available also on the website. So please, Guy, you go ahead.
Okay. How's that? Is that showing okay, my presentation?
Yes.
Good. Well, thanks very much, Petra. This is a great opportunity to talk to this audience about this landscape analysis that Monica and I worked on along with William Wells from USAID and published towards the end of 2018. It is available on the site and on the WHO site. It's 50 pages or so in which we tried to recap the background, the rationale and the trends in public-private partnership for TB from the early work led by Mukund Uplekar in particular and others from the late 90s onwards. And look into the issues, the challenges in particular, and the lessons that had been learned over those years, recap the evidence and the WHO guidance, etc. The document concluded with, there's a section in there with some information about several different countries and the situation with public-private partnership and engagement for TB at the time of preparation of that document. And of course, as we knew, that information was very quickly going to become out of date. So I think we'd all quite be very happy if through this community of practice, people from those countries in particular feel motivated to update that information and share the latest information on this website. I'm not going to go into all of what's in the document. I'm recapping some of the main points, and in a few cases, I've tried to update the data to the extent that I could. In this document, we decided to focus on the private for-profit sector rather than all kinds of public-private partnership for a number of reasons, because we felt that that's the biggest sector that's in some countries very, very important, but also presents a lot of challenges for engagement for TB, even more than, say, the non-profit sector or the unengaged public sector. What's the rationale for engaging with this sector? Well, in many of the countries, many of the highest burden TB countries, the private for-profit health sector is, of course, dominant. It's a critical part of the health system. In this chart, we're trying to show along the horizontal axis the approximate private share of primary care in the health system in those countries. And on the vertical axis, the thousands of missing TB patients. I think this was from 2017 data. And there are 7 countries here that had, at that time, 62% of the missing cases, the largest numbers, in which private providers accounted for more than 2/3 of initial care seeking. This data coming largely from DHS and other surveys. But yet they contributed only 19% of TB notifications, and that was just 12% of estimated incidents. So clearly there's a gap there. There's a problem, sort of a misalignment between our TB services and the nature of the health systems in some of the countries, not in all of them, of course. And the situation varies, of course, enormously between countries. So in that context, the rationale for engaging private providers, I won't dwell on this too much because I think this audience is interested because it's already convinced of this. But it's worth remembering that we really can't achieve any of our significant goals in TB unless we can engage effectively the private healthcare sector in these countries where it's dominant. I'm not going to dwell too much on questions of definition, but in this slide, we've sort of recapped the major, who are we talking about here in terms of the private providers. It ranges from specialists in large, sophisticated hospitals to informal or less than fully qualified providers and drug sellers, as well as pharmacies, and of course, laboratories are important. It's true that these for-profit providers sometimes give services for free. It's also true that non-profit providers sometimes, very often, charge for services. It's also true that parastatal companies and facilities or public sector hospitals also sometimes act like, in some ways, similar to private sector facilities. But nonetheless, so there are some issues around the boundaries, the margins of these definitions, but nonetheless, this for-profit health sector is huge and critical and presents some very distinctive challenges. So how are we doing in engaging them? We spent some time trying to get this data country by country, and it's not always readily available. Often there's a need to try to work hard to distinguish the for-profit from the non-profit sector. They might get grouped together. But this chart demonstrates that in the 7 countries that I'm focusing on in this presentation, the for-profit sector is usually contributing 10 to 25% of case notification in most of the countries. And that proportion has been going up in several countries in recent years. It would be good if we were able to distinguish primary care from secondary, tertiary care, but we really can't with the data available. In some cases, this data that is available and that gets reported to WHO mixes up referrals from the private sector with case management by the private sector. Bangladesh has always been very strong in this field, but in nearly all of the cases there, the data that's reported, these are cases where they were initially found and referred from private providers, but the case management may be by the public sector. And so we do have a little bit of a mixture here, but in most of these other countries, this data is largely about cases managed by private providers. But the proportion of cases that are accounted for, of course, is interesting. It arguably isn't the most relevant measure, because of more interest might be the proportion of private notifications as a proportion of estimated incidents. And this is what I present in this next chart. And again, showing the trends in recent years. What we see here is there's continuing strong performance in Bangladesh, but these, as I mentioned, are largely referrals. There have been some very strong recent gains sustained into through 2018 in India, Philippines, Pakistan, and Indonesia. Over the last 4 or 5 years, the increase in private notifications is more than half of the total increase in notifications for these countries. So there's been more attention, without a doubt. Something that, in retrospect, I wish we'd focused a little more on in the landscape analysis is that, of course, notifications by themselves don't necessarily signify service delivery, service provision. And I think we're seeing that increasingly in Philippines, Indonesia, and India. And that's what I've tried to highlight with the red bar and these question marks. With mandatory notification, which has been a very significant development in the way countries have dealt with this in recent years. In those countries in particular, I think we're seeing an increase in notification that is not always accompanied by program services. So we may be hearing about cases and reporting them without necessarily extending services or knowing the outcome of those cases. And of course, pretty clear from this chart is the continued low levels of engagement in Nigeria of the very strong private for-profit sector there. We spent some time in the document really trying to understand the constraints to private provider engagement, and I've tried to summarize them in this slide here. Constraints within TB programs, constraints in the overall health systems, constraints also on the private side of the partnership. Lack of funding, of course, being one of the most important. Very much, I think we think a very important constraint is the fact that private provider engagement requires very different skills and systems on the part of national programs and indeed the public health system in general. On the private side, clearly the fragmentation is a big problem. And there can be quite a lot of mistrust between public and private sector. I think everybody's familiar with that. But the underlying issues that give rise to nearly all of these constraints is a sort of attitude, the preference for public provision, a failure to prioritize private provider engagement, and then the mistrust that comes from that. I would argue that most of these constraints could be overcome if there was a greater commitment. And I think it's fair to say that we're seeing that in a number of countries. And of course, India stands out in that regard as having shown a huge shift in the policy environment and a commitment to dedicate resources to seriously engaging private providers. This slide is trying to summarize this. I don't think we can overemphasize this shift, the paradigm shift that is represented here. It's not just it's not a minor change that is called for by public programs, TB programs. It's a very major change that is very difficult for programs because it requires skills and attributes and systems that they haven't been developing. And I think all of us find it hard to do that. So I think we really should not underestimate the barriers if we are interested in seeing greater engagement of private providers for TB. It's going to take a huge effort. On the other hand, there are a number of developments that should make this recent trend towards greater private provider engagement go even better in the future. We've got this focus on the missing patients and recognition increasingly that many of them in many countries are seeking care in the private sector. Digital systems are going to be critical to this, in doing this successfully and efficiently at scale, and a lot of things that are possible now could not have been imagined or conceived 15 years ago when we were first trying to do this to scale. The whole movement towards universal health coverage, and in some countries such as Pakistan and such as Philippines and Indonesia, the social health insurance offers a lot of opportunities. New drugs and diagnostics are critical because they make this engagement more attractive to the private providers. We're seeing the emergence of different kinds of intermediary partners that can engage, that help us engage the private providers. Madhupai and others have led the gathering of better evidence from standardized patients and an analysis of drug sales data by William Wells and others. We're getting a better understanding of the private market, which can only help us. We've seen some new models of engagement showing great promise, and the Global Fund and other funders are dedicating some serious resources to this. And on the private market side, in some cases where there's consolidation in chains of pharmacies, that can only help. This slide is trying to summarize, if you like, the implementation landscape. There are core elements of private provider engagement that are pretty much required everywhere. Understanding and mapping the providers, figuring out the task mix, who's going to do what, why should it appeal to people. Really ensuring the right attitude of respect and engagement. It's not about going and telling them to do what we want them to do. It's about respecting their needs on the private provider side. Figuring out how to access the necessary training, diagnostics, drugs, adherence support, and then tackling the very real challenges of data and reporting, recording and reporting. We can't use the same systems when we work with the private markets. And then being good at monitoring how it's going and adjusting our approaches. I think as we look at the different models out there, the major differences that arise are whether the TB programs want to do this directly with their own staff or engage via intermediary organizations. There are differences, of course, in engaging hospitals versus pharmacies, chemists, individual providers. Whether you do it as a standalone effort for TB or integrated with other conditions. Initiatives are varying quite a lot in how they use digital technologies, and there's a lot we can all learn from each other there. International funding has been critical, but obviously over the medium long term, it's going to have to shift to domestic funding in many countries. There have been lots and lots and lots of small pilot projects, but not too many initiatives have gone to very significant scale. And then, like I said earlier, some countries can really leverage their social health insurance schemes, although that's by no means simple and straightforward, and we could talk about that. This is an area where specialist TB organizations have done a good job in many cases, but often what we see is general NGOs and broader health organizations can play a critical role, and also organizations that are specialized in engaging with the private sector. In some cases, they may not have had a lot of TB experience in the past, but they can bring a lot to this field. I think what I would focus on is just a limited number of key messages that I'd like everybody to take away from this. Is the number one rule in all of this is there's no single model. There are multiple ways to do this. If you figured out something in one city or one context, it's very unlikely that it translates exactly the same way to a neighboring city or another context. The implication of that is that we really need lots of flexibility. We need the ability to adapt and innovate. Even in the same area, if you're doing the same thing 5 years later, you're probably missing out on something. So we need to, what's called for is adaptive management. And I think that has a lot of challenging implications for implementers, of course, but also for funders and for national programs. Funders have got to recognize that adaptive management requires resources, requires management skills that have to be paid for. And governments and funders need to find ways to encourage adaptation and innovation rather than try to get people to conform to a single model. Digital systems, I think everybody's trying to do things with digital data systems, mobile phone-based systems, both for data management, but also for service delivery. And I think there's a lot more that can be done for the TB world to actually catch up with use of digital systems in other fields. As I indicated earlier, we really got to remember that notifications are only a first step. Notifications are essential to find out about these cases that might not otherwise have been known to the programs. But the more difficult and important steps are what follows. And there's no sense in delaying taking those additional steps of how do we engage, how do we extend quality services to these cases and patients that we knew are out there in the private sector. Now we're finding out about them with mandatory notification, but we really got to figure out how to extend services to those patients. And as we do that, it's about balancing carrots and sticks. We've really got to put a lot of emphasis on really powerful enablers, sustained outreach. You can't get away without doing that. And then often incentives have got to be part of the mix, carrots as well as sticks. And if you do deploy incentives, they've got to be reliable and timely, otherwise they're not effective. So these are some of the key lessons that perhaps have been learned over time. I think that this adaptation and flexibility is key. And that's why personally, I'm so happy to see this community of practice come up, because everybody needs to learn and be inspired by what we can find happening in other countries and with other programs. In the document, in the landscape analysis, we ended with a number of recommendations, but I'm not going to go into those because they align very closely with what Monica is going to be talking about in the next session. So I think, Petra, I'll probably stop there. I hope I haven't gone over time.
No, that's perfect. If you can, thank you so much, Guy. If you can get out of your screen, then yeah. I will, this was an excellent presentation and perfectly on time. And I think I would like to ask anyone if they have any clarifications. I suspect that many of the bigger questions might be coming up in Monica's presentation. Monica is going to use the roadmap as a main tool for her presentation, but I would suggest that we roll straight on into the next presentation from Monica and hold your questions. But if you have any clarifications, please let me know in the chat room right now. And again, as I said, if there are any questions, feel free to type them in the chat function, because I will collect them and bring them up for the discussion. I don't see anything right now, so I'm moving on to introducing Monica Diaz. I'm really pleased that she is with us today. She is working at WHO as a technical officer on many innovative policies related to strengthening the health system, specifically tuberculosis, and one of the big initiatives is the PPM. She's also managing the secretariat of the PPM working group and has been working in this field for quite a while. So please, Monica, I'm not gonna go into a lot of further details, and I will give you the full floor. If you want to share with the computer for your presentation, go ahead. It's now up to you to take over from me.
Excellent. Thanks so much, Petra, for that great introduction. And thanks to Guy for making that excellent presentation, which essentially sets the scene. Guy has given quite a clear overview of what's happening out there with private sector engagement, what are the key challenges and gaps, and what we need to take forward. And this community of practice, as Guy mentioned as well, is really key for all of us to come together and work together as a community to address this critical issue. So I'm going to focus on the PPM roadmap as Petra highlighted. I'm just going to get it up on my screen right now. Can you all see it? Yes?
Yeah.
Perfect. So as Petra showed you, this is a copy of the roadmap. The roadmap was developed by Guy, by Madhu Pai, the chair of the PPM working group, McGill, essentially the global, William Wells from USAID, Mohammed Yassin Global Fund, and we have, who's also, and then we have William Wells and Lal, both of who are our vice chairs of the PPM working group, who also contributed to this very critical document. So let me go back, while Guy has given you the background of private provider engagement, I'd like to go back to one important point, which is essentially about the missing millions. Now, this is one issue which has essentially, in the past, I would say 2 or 3 years, really put the spotlight back on private sector engagement. I've been working on this issue on PPM and others for over the past decade. And I believe Guy, Madhu and others all have been, William and others all have been engaged as well for the past many years. But it's really been the past 2 to 3 years where we've seen this explosion of interest in this issue. And one of the key reasons for that is to close this gap. The TB community as a whole is coming together to essentially bring down the number of people who are not reached with quality TB care. And as Guy was saying, it's not just about notifications, it's also about access to treatment. So delving a little bit into it, and I believe Guy did so as well, of the 3 million who were undiagnosed or not reported, we know a majority of them are from the private sector. And we've been doing a lot in PPM over the past years, over the past decade actually, but again, you see marked a lot of progress, especially I would say over the past 2 or 3 years. And you can see it here. So this is public mix. If you look at, this is the latest data from our WHO Global TB report. And here you can see when we look at public mix, which is not private, but it looks at public sector care providers who are not engaged. You can see that there's been an increase, for instance, in Thailand, Indonesia, Vietnam, where these care providers who are also often the first point of care, but not directly linked to the NTP, there's been a greater engagement and greater contribution from these care providers. If you go into pure private sector engagement, if you look at public-private mix contributions, again, you can see the marked increase, especially starting from 2015. And this is where for the first time this year in the WHO Global TB report, we were able to announce this huge decrease in the gap. We went down from 3.6 million, which was the gap, down to 3 million. It's never happened before, and a lot of this success is attributable 2 two countries such as India, Indonesia, Pakistan, Philippines, Myanmar. A lot of those, the contribution to notifications comes from increased private sector engagement. So Guy touched upon basically which are the countries where there is a huge burden, but what we have called these countries with a huge private sector are the big 7 that we are targeting as part of our PPM efforts. These countries are India, Indonesia, Myanmar, Nigeria, Pakistan, Philippines, and Bangladesh. And here you can really see the gaps. You can see if the red signifies basically the people who are missed. And again, these are countries with large private sectors. And we know that around 80% approximately of people with TB in these countries are probably accessing care from providers who are either in the private sector or the public unengaged sector or the informal sector. And closing the gap on this really requires a scale up of PPM efforts. Drug-resistant TB remains a public health crisis. Again, only 1 in 3 people with drug-resistant TB accessed quality care. And again, the treatment success rate is quite low. Again, this is an area where engagement of the private sector can help close this gap, which is even more exacerbated for drug-resistant TB than for regular TB. And then there's been this other area that we've, again, when we've been looking at PPM, we've not really focused much on, except for the past few months. We've been working very closely with the Childhood TB Working Group, and we've done a little bit of analysis on this. Now we know that, so we have 3 million people overall missing, who miss out on access to quality care. Of the 3 million, over 500,000 children with TB miss out on access to quality TB care. And we know that many of them are either with, again, with pediatricians in the private sector or in the public unengaged sector. And I've done a bit of analysis on this. So as I said, there were 500,000 kids who missed out on access to quality care. And if you do a little bit of rough calculations with our big 7, you can come out with the number of children missed. And the big 7 essentially accounts for 400,000 of the 500,000 children who are missed. So again, this is a critical area where we need to, so basically addressing TB in children and essentially engaging all care providers in this effort is something critical that we all need to join forces on. So as I mentioned, there's been a lot of work that's been done. Again, WHO has been very closely engaged for the past, 15 years or more, actually maybe 20 years or more, in efforts to scale up engagement of all care providers. Back from 2002, 2010, we had a toolkit, and 2014 to 17 saw a burgeoning of interest. And then we have in 2017, I would say, with a lot of global fund focus. And then we had the launch of the roadmap in 2018, which has really pushed forward. And I'd like to show a quick glimpse. This is our PPM working group meeting at The Hague, and Guy will recognize this. Petra, you weren't with us at this point, and I know, I was looking at who has joined. A few of you were part of this. You can see the happiness. We've launched both the PPM roadmap and the landscape analysis, and this really signaled a major turning point, because we now have this strong tool which outlines 10 key actions, and there's great direction to move towards. And I'd also like to share that we, at our 14th PPM working group meeting, which happened last year in Jakarta, where we had around 250 participants present from across 20 countries, Again, we saw that countries have already begun to take here again is a roadmap and the landscape analysis. So this is really the right moment and the right opportunity for us all if we want to ensure that we can scale up private sector engagement and basically engage all care providers in efforts. As I said, have been the linchpin for all of it. We've had, and the main reason is the focus on the UN high-level meeting political declaration, which talks about the 40 million, as well as the Fine Treat All initiative that we have with Stop TB and Global Fund, as well as the whole, we have the Global Fund strategic initiative. We have, when you look at the broader picture, the whole push towards universal health coverage, WHO's triple billion targets, in our 13 general program of work, all of this has put so much high level attention on reaching those people who are missed, that countries, national programs, which were earlier not very receptive to looking outside the box, are now looking at private sector care providers as potential partners that achieve this goal, because the pressure is now on, given the commitments that have been made. We have positive and promising examples, as I already said, in Japan, Bangladesh, etc., with rising PPM notifications. We have new digital technologies which can help in better monitoring, in better treatment adherence. We have so much. We have new tools, from expert to shorter MDR TB regimens. We have new diagnostic tests, which are now being all the new tools that the public sector has that can be used as incentives to encourage the private sector to work closely together. And of course, we have this push towards universal health coverage, social health insurance, again, which can help us achieve this goal. So all of these are to scale up public-private mix. So our roadmap essentially is focusing on countries that make a difference. I already mentioned the big 7, which is where the biggest burden lies, but we have a total list of 15 countries. And again, when we talk about the PPM roadmap, it's about strengthening private sector engagement, as well as getting public unengaged sector, such as the defense sector, where there are potentially cases, prisons, or large hospitals, including children's hospitals in many countries, which are not reporting, getting all of them on board so that we can ensure that people with TB access quality care no matter where they go. So the PPM roadmap has 10 key priorities for action, and I'll run through these quickly. So as part of these, as part of the 10, the very first is of course about what we need is greater understanding about patient preferences and rationale for engaging all care providers. And we have excellent tools at this point, starting from the patient pathway analysis that was commissioned by Gates. We have a people-centered framework that WHO, again, with the support of Gates, has launched. We have better EPI reviews. We have, all of this can help us. Basically, it makes the case and helps national programs and the political powers that be to basically invest more in this. The second one is, of course, we need targets. If we do not have appropriately ambitious targets, the needle is not going to move. And this is what we've seen with the UN high-level meeting declaration. There are commitments for targets, 40 million, for instance. This basically puts pressure on all countries if they have to close the gap that they have. And this is excellent because it does serve as a very good motivation. But again, we should be looking beyond just notifications, but looking more at coverage targets. So are these people really accessing quality care? Are they completing quality treatment? And so we need to have meaningful indicators for this. And this is essential to promote accountability. We need to advocate for political commitment, action, investment, business unusual approaches, no one size fits all, as Guy very strongly elaborated. You know, every setting, every country is so different. And we need political commitment for these business unusual approaches. And there has to be an environment in which all healthcare providers are motivated to provide quality assured TB care. And we need to engage community, civil society, and media for the other demand side push for political commitment, for translating those commitments into action. We need to, of course, have financing, and we need to capitalize on universal health. About UHC cannot be UHC if you're just talking about pure public sector. It's about the patient. Wherever the patient seeks care, they should have access to quality care, and that's why private provider engagement needs to be prioritized. And that's an option. The fifth one is, again, is partnering with intermediaries and other key stakeholders. Again, national TB programs with the WHO NTB strategy. We went from the Stop TB strategy with around 6 key actions to the NTB strategy, which is 3 pillars, which encompasses multiple actions. We have a huge burden of TB, drug-resistant TB, TB, HIV. National TB programs are already overwhelmed. And there are multiple agencies, and Guy gave many excellent examples of which types of agencies or partners could help bridge the gap. And it's essential to see them as key partners to help drive the process, to help reach those people who are missed. So this is really critical. And the next one is, we need supportive policies, we need regulation. And not just regulation, but enforcement of regulation. This is really key, given that, so we have, for instance, mandatory notification has always been a regulation from, I don't know, the 50s or the 60s, if you dig into literature, but it's never been enforced because there's been no means of enforcing it. You can't expect a private sector provider to fill in tons of paperwork and submit it. And we heard this very aptly from many private providers who spoke about this at meeting and said, how would we have been able to report? And digital technologies helped solve this issue. So it's really simple with digital systems such as NICSHI and other systems in countries to make this work, where it's simpler to report cases, to follow up patients and all of that. And again, coming back to the need to recognize that there is no one size fits all. We need to have flexible engagement applicable to different contexts, and these need to really be flexible and output focused if we want to see any real impact. Again, coming back to digital technologies, this really has been key in driving this issue. And so we really need to be using digital technologies in all our work for PPM. And the good news is that most countries, as Guy will say from the reviews he's attended and other partners as well, again, all countries seem to be moving in this direction of looking more at electronic recording and reporting, and to apps and access, basically enabling access to even private practitioners to these technologies to facilitate notifications. Again, we need incentives. Not everything needs to be financial, it depends. I think the main thing, again, is trust in keeping promises maybe is probably the strongest incentives. Non-financial incentives also may work better, such as giving accreditation or, I don't know, branding. There are so many things. But of course, financial incentives are important, especially if providers are giving their time. It's not a charity, they're also providing a certain service. So they should be compensated commensurate to the work that they're doing. And as I said, we need to address accountability, otherwise we cannot justify taking this work forward. And our roadmap therefore has timelines and targets. This year will be a key year for monitoring work in areas of financing coverage, outcome targets, and monetary evaluation, especially in our priority countries. We will be working this year to set up a dashboard, and we welcome a lot of input to this issue, to the area of work. And we have targets all the way down to the end of the term of the NTB strategy, which is 2035. So in conclusion, we have a great tool in our hands, and what's important is that we as a community come together and push for the commitment we need, push for the investment we need, and the actions we need to basically make this roadmap a reality. And we're very happy to work together with you on this as a team. So look forward to hearing your questions or suggestions, and look forward to working together with you on this. Thank you. Over to you, Petra.
Thank you so much, Monica. That was a really good, detailed presentation, and it was great to hear you talk about all the different steps in the roadmap. To everyone else, I would like to just say that both presentations, including this recorded webinar, will be available on the TBPPM community website. You can log in and look at everything afterwards. I have been trying to keep track of the many comments and questions, and I'm really pleased to see how engaged everyone is. I'm trying to, I have also, if you want to say something, please raise your little hand in the chat function, then I can call on you, or let me know that you want to have a comment. We have about 10 minutes to take a few calls. I've tried to lump some questions together. I have about 5 different questions that have to do with incentives. Like, how do you sustain incentives for volunteers, incentives for the public sector, and for private, what kind? Can you give examples? And how can we sustain the engagement of the private sector with incentives? So that's lumping about 5 different people who have asked questions in that regard. And that would be nice if one of you or both of you can address something. A second thing where people have commented in these comments, and by the way, all these comments I will be posting as well. And if I see that there are many questions around one topic, I will start a discussion thread on our community site so that you can also engage around this topic specifically. So incentives definitely will be one. The second one is more about the perception of the private sector. So what are barriers to the private sector, and what are actually the private sector perceptions itself? How can we respect the private sector to be part of our community? And do you have examples on how we engage with the private sector? Then there were a few comments related to the missing cases, and how do we get the community and clinics involved in identifying and notification? And how can we get profit-making organizations involved in the missing cases? How can we discuss that argument? And maybe a final point that came up, how is the TBPPM integrated within the bigger UHC agenda? So I want to give the floor to both of you to maybe address some of these, and then afterwards I'll take a few people that want to say something and try and call on them if we have enough time. Monica, Guy, do you want to start? I see your mouth open.
Yeah, well, I'll try to make a start on the incentives question. It's a big topic that we don't have a lot of time to deal with properly. I think it's important to understand that we can do a lot working on the fact that the private providers are very motivated to offer good services to their patients. So an incentive for them to participate in a well-designed program might be that they like the idea of getting their patients to have access to free drugs and free diagnostics. Why? Because then their patients are very grateful to them for having helped them get access to those. So the provider can be motivated by the benefits that he or she can help the patient to access. We should also never neglect the fact that non-financial incentives are very powerful. Professional self-esteem is important for many, many people. Being part of something big is important. Getting recognition from the government is often very important. So at the same time, we shouldn't think that the private providers only need money, that otherwise you can't do anything with them. At the same time, it would be a mistake to neglect money. It's all a question of feeling our way and finding how far you can get and whether you're coming across barriers. For example, a small amount of money can be quite a significant incentive for the assistant of a private provider if you're asking that person to help you with the record keeping. That money may be much less than would be important to the private provider, but for a low-paid assistant, that could be quite significant, a token amount. In the final analysis, though, TB control costs money. And health professionals are health professionals, or service providers, they need resources. So I think eventually programs have to get over the mental barrier of deploying incentives. The India program is doing so on quite a large scale at the moment, which is a part of its improved performance in private provider engagement, is just being willing to make available financial incentives as well as part of the package. So it's not essential, but it shouldn't be neglected completely either, and it can be quite important to go into scale.
Thank you, Guy. Monica?
Perhaps I can add, I can quickly add to what Guy said very clearly. So financial incentives are important, and perhaps they can be critical at initial stages to basically change behaviors. It could be a starting point. So we've seen that often, so on both sides, both from the patient side as well as the practitioner side. As Guy very clearly pointed out, we've seen that, yeah, for practitioners, again, it may not be so much the money that's important, but again, the recognition, perhaps better branding, accreditation from the government, these things can be critical. Perhaps to kickstart the engagement, financial incentives could play a certain role. And once the behavior changes, both of perhaps gaining greater acceptance of openness, both on the NTP side and the private sector side of collaboration, it might be something that could be sustainably then carried forward, given this question of sustainability that was raised. But again, what would be more powerful, which we've seen, and there have been several papers published on this, is that often non-financial incentives, such as awards, or through the medical associations, these accreditation-based incentives or licensing incentives, all of these could have a more powerful role compared to financial incentives. So yeah, just to add to Guy. Guy, do you want to go to the next question and then I follow through?
Well, I'm not sure I can contribute on all of them. I think that the issue raised about how this fits in with the broader UHC agenda is a very important one. Mm-hmm. The broader UHC agenda, of course, is itself many different things to different people. But in many of the countries, UHC can't be achieved without engagement of the private sector for all health issues. And I think TB can certainly play a pathfinder role in showing how to engage the private providers. I won't get into the details, but I think there are various attributes about TB that make it a good issue to start with for a country that wants to engage the private healthcare sector as part of a broader UHC reform. When the broader UHC reform includes a social health insurance scheme, that poses challenges as well as opportunities for TB, and as has been found very clearly by Indonesia and Philippines and some other countries.
Monica, did you want?
UHC front, on the UHC front, I'd just like to add that at the World Health Organization, we're also looking, I mean, the UHC team, the health systems team is also looking more at private sector engagement, because, you know, across the organization, we've been looking, like different disease areas, like malaria has been doing a bit of private sector engagement, HIV a little bit more. the medicines unit does a little bit, but it's not really cohesively come together. And so the team that handles universal health coverage is looking at strengthening private sector engagement, and they've pulled together an expert task force on this issue. And I'm very pleased to share with you that they've actually looked at they've taken our PPM roadmap as a good practice document, and they're basing a lot of the work that they're doing on our roadmap to strengthen private sector engagement. So this is really key. And I think Madhu is on the line, and I'd like to give Madhu the floor perhaps to talk a bit more about it, because again, as chair of the Public-Private Mix Working Group, we recommended that he be part of this expert panel or expert task force on UHC and private sector engagement. And he's been basically driving a lot of this agenda forward through this task force. So Petra, I would suggest that if Madhu is online, we get him in to speak a little bit about this, because this is indeed a very critical area.
Thank you, Monica. That's great. I'm looking to find in between our 50 participants online to see if I can find Madhu quickly. I don't see him right now. So considering that we have only 5 minutes left, I would like to give Ria Lobo the floor. She's asking to say a few things. So please, Ria, go ahead and say what you would like to bring forward.
Hi, Petra. Thank you for giving me this opportunity. Great presentations, Monica and Guy. So just to quickly introduce myself, I don't think I know many of you. My name is Ria Lobo. I am a filmmaker by profession and a TB survivor. And I actually was following Guy's presentation very keenly. And particularly the Guy had a slide on rationale for engaging private providers. And if you look at all the points that Guy raised, there really essentially is one thing that, as in my own personal experience with TB, is the fact that doctors are screwing up. Private doctors are screwing up, and for me, it just seems like, I mean, as everyone went through their presentation, there was just this one part that I really wish in these circles get highlighted more, and that is training. Okay, because in my own experience, okay, I first went to a doctor, a general practitioner. I mean, I went to an orthopedician actually. I had bone TB, and I was referred to a specialist. And this, I mean, I'm one of the privileged people who get referred to a specialist to begin with, because a lot of times the GPs just dash out the drugs. So it's more like, and the specialist screwed up. So you can imagine how bad the scene is, and how the specialist screwed up was with my dosages. So these are very practical things that happen on the ground, which I just feel like, I mean, the specialist that I met was a very full of himself, the typical private provider that you would find. You couldn't really ask questions. There was no treatment literacy, none of that. And I suffered endlessly because of this less dosages, the less dosage of medicine, and so it just, to me, I really want training of doctors to be highlighted more. I saw Guy highlighted it in the modality section, and that was great. And but I think, in India, the real life scenario on the ground is, from what, I'm a journalist as well by training, and I understand just a few hundred private doctors get trained on the latest guidelines, on the latest, they go to a place for training every year. So, I mean, it's just, to me, given the scale of the problem, and roughly 75% of Indians go to the private sector as a first point of care, it just, I just think that, I mean, I really request everyone here in this group to please give training a bigger piece of the pie than it already has. Then. Thank you.
Thank you, Ria. Sorry, Monica, Guy, I'm conscious that it is 11 o'clock. I would love to give you a final word, both of you. In the meantime, I want to say thank you, everyone who has been giving comments and questions. I'm sorry if we have not been able to address them in this call directly. I will be posting every question with your name on our website, so that I will be asking both Guy and Monica to later today or tomorrow to reflect and look back at those questions so that they can answer individually. This will all be available in the interactive forum on our site. So please feel free also to log in and to check in and post your questions there directly already if you want to. Otherwise, I will be taking all the questions from this chat and posting them there with your names so that they have a chance to go over them individually. But I would like to give you both the last word, and thank you both so very much for your excellent presentations and your time.
Thank you too, Petra.
Good.
Guy, would you like to go first and then me, or vice versa?
We can maintain that pattern, sure. Thank you, Petra, and thanks everybody. I've been following all these comments and questions, and I'm looking forward to engaging with all of you in responding to them, and then keeping up the dialogue, because we've got so much to learn from each other, and that's the beauty of this community of practice. We really have to make this vibrant. Thanks for all your comments and for the attention.
Yes, I would like to echo my thanks too. I can already see the questions keep coming in. And this is what the purpose of this learning network really is. It's a community forum where we finally have this platform to come together and discuss. I'd like to also end with to thank Ria for, again, keeping it real, as you always do, Ria, which is good, and bringing the pain of, I mean, we are all doing this, all the work that we do is around the people who are affected, and Ria really expressed the pain that she feels in her experience, and I completely agree there is a lot that requires to be done. We are currently prioritizing training, and I'll be happy to share sometime, perhaps in the future. This year, we're working towards better training materials. And for instance, the PPM roadmap will be transformed into a more modular training-like format that can be easily accessed and easily used, perhaps in app form. Maybe you don't need to take 100 doctors away to do CMEs and train them up, but we're looking more at using technologies to achieve this. This platform could be one that could also be a portal that we could encourage or drive practitioners towards if they have questions or they'd like to get more information on. And of course, we need more awareness. And again, we need the power of civil society to help us in this area. The other thing I'd like to quickly highlight is that regulation is key. And I see that there are a lot of questions on the side linked to regulation as well. And that's one of the critical factors of PPM, is that if we start partnering together, then it also becomes easier to regulate. You then, once you get into a partnership, you can basically then start correcting each other, moderating each other, and that's been critical. So regulation is key, and I think through PPM, we can push forward for regulation, of course, with a few carrots and incentives thrown in to make it work. So again, thanks to you all, and look forward to taking this discussion ahead, forward. And I will be responding to a lot of the questions that you've been pouring in, and feel free to reach out as well. Thanks, Petra. Thanks to Madhu, and thanks to you all as a learning community. Thank you.
Thank you very much to everyone. I'm wishing you a good rest of the evening, afternoon, or morning. Many warm greetings from snowy Ottawa. And I am looking forward to be sending out the details of this webinar, and looking forward to all the discussions further online. I think there's a lot more to say on the presentations, so please all check in. At the same time, I'll be also working towards a next webinar, and please look forward to mid-February. We will be posting what the topic and the speakers will be. Thank you all for joining. And with that, I'm going to close this presentation for today. Goodbye.
Bye, thank you.
Thanks a lot. Bye now.